everyone. Welcome. Thank you so much for joining us today for our interoperability panel. We will kick it off momentarily, but we appreciate your attendance today. So for anyone who doesn't know, I am Robbie Felton, the CEO and co-founder of Intus Care. I'm thrilled to be moderating today's discussion. Before we get started, a few quick housekeeping items. This event is being recorded, and the recording will be shared with you afterward. Feel free to post any questions in the chat. You can also upvote questions, and we'll select a few for our panel to address at the end. Thank you for joining us, and let's dive in. My journey in PACE began through my mother's experience as a geriatric social worker. Visiting PACE programs across the country, I saw firsthand how disconnected systems and fragmented data were holding programs back, with care teams spending precious time wrestling with technology rather than focusing on participants. This experience shaped our mission at Intus Care in today's discussion. Our goals today are to explore how true interoperability can enhance staff satisfaction, improve participant experiences, and drive better outcomes, while sparking a broader conversation about how technology can better serve PACE's unique model of care. We have an excellent panel of experts joining us today who bring diverse perspectives on these challenges and opportunities. I look forward to a rich discussion about leveraging interoperability to strengthen PACE and better serve our participants. With that context, I am honored to introduce our first panelist, Dr. David Feinberg. David is a world-renowned healthcare leader and serves as the chairman of Oracle Health. Formerly, he led major health systems, Geisinger and UCLA Health. David, thank you so much for being here.
Oh, my pleasure.
We also have Stephanie Rock, the Senior Vice President of Product and Client Delivery at Intus Care. Before Intus, Stephanie served as the Vice President of Product at Oak Street Health, where she helped design their care delivery and data platforms that scaled to hundreds of clinics and providers nationwide, ultimately serving hundreds of thousands of patients.
Thanks, Robbie. Excited to talk.
Thank you very much, Stephanie. We will also have Shawn Bloom joining us. He's running a little bit late. He is the CEO, the multi-decade CEO of the National PACE Association. He has led PACE to become the national agent for positive change in senior care that it is today. When Shawn joins, we will introduce him further, but we'll kick off the discussion. I want to highlight the key historical milestones in healthcare interoperability. Before 2009, healthcare ran on paper records. Think faxes and physical files moving between providers. Then in 2009, the HITECH Act digitized healthcare through incentivizing electronic health record adoption, but inadvertently created digital silos, electronic systems that couldn't talk to each other. The 2016 Cures Act was a turning point, making information blocking illegal, although it still happens today in some cases. By 2020, CMS began requiring standardized data sharing, and then 2020 brought TEFCA, which formalized our first nationwide framework for health data exchange. Today, while 70% of hospitals participate in interoperability initiatives, PACE programs are just beginning to see these developments in practice. For PACE specifically, true interoperability means creating seamless data flows across all touchpoints, from day centers to specialists, transportation to pharmacy services, anything you can think of, all supporting our interdisciplinary care teams. In my opinion, in PACE today, we are at base camp and are just starting the climb towards a vision of data-enabling comprehensive coordinated care. I'll kick it off with Dr. Feinberg. You've spent time as a frontline clinician leader, and now as a technology leader. Pulling from all those perspectives, what does interoperability mean to you today, and why is it important for patient care?
Yeah, well, super excited to have this conversation. Interoperability is a big word. I'm going to try to break it down. So now at Oracle, I previously was at Cerner, and we were bought and brought into the Oracle family, which has been fantastic. But if I can use the old term Cerner, even though we'll probably rebrand it, I describe us as the largest electronic health record company in the world by far when you look at market share. And not just because I'm talking to a PACE audience. The next thing I say after that is that means we have more of grandma's blood sugar than anyone else, right? So think about grandma's blood sugar. The first thing you want to do with grandma's blood sugar is keep it safe and secure. So I think cybersecurity has to underline everything we're talking about, because healthcare is people caring for people, and it's based on trust. So we got to keep grandma's blood sugar secure. And then the next thing we need to do with it is get it to the right person. And the right person could be grandma if she's doing self-care, maybe an adult child that's helping grandma manage her blood sugars. Maybe it's her primary care doctor. It could be an endocrinologist. It also could be a case manager who's managing a lot of grandma's and grandpa's blood sugars. The other thing that's important about that particular lab result is there's a lot of other information falling under that category of interoperability that I want to know when I see an abnormal blood sugar for grandma. What's the hemoglobin A1C? When's the most recent foot exam? What about diabetic retinopathy? So when we see something like that, when we say we want data to flow, really what we want to do is to make sure it's secure, and then that it comes with everything else we need to say, hey, we're managing grandma great, but we see the social determinant information that also flows with it. And really what we need is better food in the cupboard. So that to me is the use case of why it is so absolutely important to make sure, to your point, Robbie, there isn't information blocking. Information blocking to me is the same as saying bad care.
Yeah, that's so insightful. Thank you so much, David. I totally agree. The information security and then the share of that information, most definitely top of mind. And I see we now have Shawn on the line. Shawn, I'll actually kick it to you next. From your perspective, leading policy efforts in PACE, what do modern interoperability standards unlock for PACE programs, and/or what are the most pressing challenges they solve for the PACE model of care?
Yeah, thank you, Robbie. And my apology for being a little bit absent-minded and getting too focused on my work that I was involved in. So it means a lot, for I think to the extent that you understand PACE, we are, probably one of the most, if not the most comprehensive model of care in the country. So our consideration of services and what's rendered and where and when and what data was collected at that point is paramount to our ability to provide effective care. So interoperability at its core really means access to information to identify individuals' needs, to plan care, deliver care, monitor care, and to achieve the outcomes that we're motivated to provide each of our participants. So, I think similar to what Dr. Feinberg said, access to the information is extremely important. And I think the notion of interoperability is really a means to really gather information across multiple settings. While the majority of care is delivered by PACE staff, it's universally true. We contract out for acute care, we contract out for long-term care services, and a few other pieces. If we can't monitor and gather and retroactively the information that's been gathered during care in those settings, we cannot be effective in achieving the outcomes that we've enjoyed so far. So it's essentially important to us.
Yeah, I feel like those two responses tie together. Access to information very much leads to better care. I think that's a great segue to you, Stephanie. I would love for you to comment from the product perspective and what you've heard from the other panelists. Do these responses resonate with you, and how have you thought about interoperability as you've built clinician-facing EMR technology?
Yeah, definitely. The definitions definitely resonate with me, and I think hit on a lot of the most important points. I think simply we want to be able to share information, and I think what I've seen today is that actually a lot of that is being done manually in PACE, and I think what's really, really important when we're building out EMRs is that we actually really want to automate a lot of that work, and we want to make it simple and easy so that the teams are not actually focused on manually sharing information with these external parties that they're working with. I think from a product perspective, that should be managed by the systems and technologies that PACE is purchasing. That's a super important step in having that be automated. We want to, at the end of the day, allow the teams to care for patients and focus on that and think a little bit less about how they're getting medical records or how they're entering data that's coming in externally. And I think even taking it a step further and getting to a point where that information is synthesized and actionable and easy to use. So I think we really want to automate that for teams and make it part of the systems they're using day in and day out.
Yeah, that makes a lot of sense, Stephanie. And I guess redirecting towards more of the system-wide changes that are coming. Shawn, I know in 2025, there are various regulatory changes that impact PACE plans. Thinking specifically about new PACE programs, how should they be critically thinking about interoperability?
Yeah, it's tempting to really dive into the full range of final regulatory changes that are going to take shape in 2025, but I'll speak kind of more categorically. I mean, I think the modifications of the rule impact everything from intake and enrollment all the way through the service experience of participants in PACE. So I think when it comes to interoperability, I think for new programs in the context of the new reg, I think it's going to be important to assure close data exchange relationships with contract providers and others. So for example, when you enroll a new individual, you ought to be able to have access to some of their historical care records, correct? That sounds really simple and fundamental. It's a much more difficult challenge than one could imagine. One thing that interoperability does facilitate is access to that historical information and some kind of, if necessary, interaction with previous providers. Because we do know that individuals that are enrolling in PACE have likely been through a service trajectory that it's led to some sentinel event, which is quite common. And it is very, very important, both clinically as well as I think for the sake of the individual in general, to really be aware of their past clinical and service experience. So interoperability has been and remains very important. And there's various elements of the new proposed reg that I think really reinforce the importance for PACE programs to be aware of that.
Hey, Robbie, can I add to Shawn's?
Yeah, that'd be great.
So I think what Shawn's saying is absolutely crucial, and I want to add one thing on top. So as we move toward more and more interoperability, it actually creates a very, very big challenge then for that person who's enrolling that person in the PACE program. So if I said to you, okay, we've solved this, here's all the records, I know, and we've actually looked at this, that 99% of that person that I'm admitting's record, if I look at their laboratory, if I look at their medication list, if I look at their problem list, is duplicate information. So you grab all this information on people and you basically throw them a bunch of haystacks and say, try to find the needle. So not only do we have to have the records fluid from an interoperable standpoint, we have to make them longitudinal so they make sense. It tells the story of the person, and then deduplicate them. And deduplicate them in a way that the system knows what you know about the patient and what you might not know about the patient. So in essence, we fix interoperability. The patient tells me or their family their medication list. There is one medicine out of the thousands of duplicate medical records out there on this patient that I'm unaware of. I need to know it right at that moment. So it's interoperability, make it longitudinal and deduplicate it so that it's usable. Because if we kind of go back to the olden days, when I would see a new complex patient in my training, they would bring from Iron Mountain these manila folders, 1 of 14, and they were stacked up. And they said, you got a new patient. Well, I didn't read the 4 feet of records, but you've kind of flipped through it and you tried to find it. The tech now is something such that now not only did we get the manila folders to show up, we can make it so it's easier for me to actually find what I'm looking for. I just think it's an important, we will say to these frontline clinicians, hey, we solved interoperability. Here are the records on this patient. Yeah, but it's in a PDF and it's scribbled and it's duplicated 9,000 times. We didn't really solve their problem. We solved the data flow problem. So I just want to add that to Shawn's answer.
Yeah, and I just got to say, I really appreciate you adding that because, I think the sheer notion of just getting a data dump of all historical records is not always helpful. And it stands to reason that the individuals that come to PACE and are eligible for PACE have very significant health needs. So there's some degree of kind of urgency to be aware of what is their most immediate recent status. What medications are they on? Are they on any kind of treatment regimen? So on and so forth. So the immediacy of needing to know is pretty significant. So Dave,
And
I
if
appreciate
I'm the
you adding that.
cardiologist, Shawn, if I'm the cardiologist that's consulting to the PACE program, I want to see the information in a different way than if I'm the nurse practitioner doing an admission, right? So it has to also then be context specific all of a sudden. Well, we now have the tools to do that, but I think it's really important that we don't lose sight of those things as we solve this interoperability thing.
Very well said. Boy, if there's one thing we should learn today about this subject, it's just what he mentioned. I think that's just paramount.
The webinar is now over.
Yeah, we're all done. So.
Yeah. So David, you touched on something pretty impactful there. You mentioned a longitudinal deduplicated context-specific electronic medical record. Is that the standard today? And if it's not the standard today, when is it going to become the standard?
I want to be able to answer this question and not do a commercial for Oracle Health. Yes, that is the EHR that we have built. We have folks using it. It'll be general availability in the first quarter of next year. But think of it as no clicks, totally voice enabled. And so you could say as a PACE person, hey, when was this person's last vaccine? Has this person had any issues around anxiety or panic attack? And that information just comes to you, right? So to Shawn's point, it's interoperable. We grab all that stuff. In the background, it's been deduplicated and longitudinal, but then that context specific is how you would then interact with it. I would say the best news, now I'll talk generically, and this is really because we've had such a opportunity with this new kind of AI stuff. Within a year, that's how folks around PACE should be interacting with this data.
So
a year, I don't want to get in trouble. Let's say by the end of next calendar year.
yeah, that's from a technology perspective and a provider experience perspective, that's very exciting. Given it's not the standard today, who's the onus on to make that longitudinal deduplicated context-specific record? Is it the provider? Is it people at the organizations? Who's doing that work at this time?
So I always say, if you get sick, the best thing you need is a daughter, especially if you're an elderly person, right? And so who's the onus on? It's on the family. Like in the PACE, it's the daughter who comes and goes, no, my mom had that. No, and it's not because daughters are better than sons at this. It's usually the sons don't step up. So it's that alpha mom who's caring for everyone at home, including the parents and the in-laws. And I'm obviously stereotyping, exaggerating, but that's who it ends up on, because the frontline PACE workers don't have the time. You to go through those 4 feet of records, or now those 4 feet of digital records. You can't do it, and you end up saying, well, I'm not sure that they had a Pneumovax. Let's give another Pneumovax. But the current onus is on families and patients, and as I exaggerate, these alpha moms.
No. I think it's absolutely the case. And I think if you talk to any kind of intake team in PACE, they'll tell you that engagement with the family early on to kind of answer some very, very basic questions is a starting point, but a very essential starting point. And then being aware of how PACE programs have done this over the last couple of decades, there's an enormous amount of human effort that goes into just answering basic questions about the recent medical history of the people that we're enrolling. And it is enormously challenging. And it's a very, very imprecise process as well. And, one thing interoperability and I think enhanced technology can bring is an enormous degree of improved awareness and knowledge of the patient's conditions, and better approaches to meeting their needs right out of the gates after they enroll in PACE. Yeah. But I also think the onus of burden is really on the technology community to really generate new solutions that put in the hands of clinicians in particular access to that information in a way, to state it in David's manner, that's longitudinal, non-duplicative, and offered in the context of the clinician in terms of what they need to be an effective caregiver. So
yeah, it's so trust eroding what you described, Shawn, that human saying to the family, and grandma's there and they're not doing well, hey, can I get all this information? And while they're doing it, they're looking at a computer and the family's like, isn't that information in the computer? And maybe it is, it's almost impossible to find. So it just trust eroding at that moment, that very important moment if we're making a decision about what to do with grandpa. Like it's as opposed to, we know who you are, we've been expecting you. There's a couple of questions that are subtle that I need to ask you, but I know you're
right. Then the question should be more to clarify and kind of bring together the information that's available to you. But I just remembered that someone once referred to this as the initial scavenger hunt.
Yeah.
You know, you talk to the family, who was the PCP, you go to the primary care doc, you get the records, you find that there's been a recent hospital stay, you dig into that. It's truly an informational scavenger hunt. And it would be wonderful to think forward to a day where we move from the enormous human energy that's put into that scavenger hunt to rather building and enhancing our knowledge about the person's needs and likely the effectiveness of the design care plan. So
yeah, you know, she takes 1.5 of those blue pills at night. Like I've heard that so many times. I'm like, oh, great.
Yeah.
I'll order 1.5 blue.
Yeah, would have blue pills. And they're square, right? So
exactly. Sorry.
I think one thing to add that I feel like the longitudinal record is so important, but like even from a technology perspective, as we think about how to expand that longitudinal record, and you all are talking about like the caregivers and family members actually adding to that, like collecting the social determinants of health and like family and caregiver information, personal care information within that longitudinal record, because all of those are so impactful on patient outcomes. Even like remote patient monitoring and all of these things, I think, like not just medical records, but really ensuring it's like this really holistic longitudinal record that the teams have access to. And again, I think, like David said, is tailored to that person that wants to see it. You know, PACE is an interdisciplinary team. And I think what home care wants to see might be different than what a PCP wants to see. And so being able to really collect all of it and tailor it is super important.
And Stephanie, Shawn made a point about it being a scavenger hunt. How do you think about turning that scavenger hunt into instantaneous insights and workflows? And also, what are some of the key PACE workflows that you think require interoperability to function seamlessly for the care teams and the participants?
Yeah, there's so many workflows that require it. I think, like I said, the model, because it is an interdisciplinary approach, I think what that means is that it's very comprehensive, but that creates a lot of complexity as well. So, you know, at a really simple level, getting all of that information for the time that they're doing assessments and care planning to actually minimize the amount of time they need to spend asking questions and collecting information, but you kind of already have that at your fingertips to really create a tailored care plan that is going to solve the needs of the patient and the family to get the best patient outcomes is super important. And I think, like both of them said, there's so much outside care happening. All of PACE programs use a lot of systems and vendors to help them actually support the delivery of care. And if you don't have the information going back and forth and then getting put into an easy to use format for people to actually inform decisions on, like all of this is around care coordination, external information. So as they're going to specialists and facilities, all of that is super important. So I think that that's very baseline, is that in order to do end-to-end delivery of care, you can't just have the information that's right in front of you and the person is in front of you. It has to be all the time. And this is, I think, resonates across all of these complex full risk models where you're really responsible for the person end to end and their health outcomes.
Yeah, Stephanie, I think you introduced a really important observation that not all the information that we need to have interoperable is tied to the medical record. Now, we all know that a lot of that information will probably, a lot of what we need in the way of the social determinants and the family circumstance and the environmental circumstance, you know, it may not ever be appropriate to really make that core in it, and you know, electronic health record. But I think what you've touched upon is the uniqueness of PACE, that we really look at an individual's needs and deliver care through what I call kind of the three prisms of clinical needs, social structure, and environmental factors, right? And it's really hard to think about purely looking down a clinical pipeline of information. You've really got to be mindful. And I think it stands to reason that that's the reason why you see all these multiple data sources in PACE.
Yep.
And I do think there's a degree of what I call macro interoperability nationally, but I think within the PACE program, there's also, I think, the need to begin integrating and creating interoperability of disparate forms of data as well, as we know.
Yep.
And that's perhaps another topic in general, but yeah, I'm glad you brought that up. That's a very important observation.
So Shawn, at your role within the National PACE Association, I'd say you all probably have the best insight into the role of interoperability across the complexity in PACE. How do you see the National PACE Association continuing to promote interoperability over the next few years?
That's a very good question. There's probably no one single solution to that. You know, we've had a long history of working with some of the vendors surrounding PACE. We're definitely doing our best to support the evolution of new technology solutions in PACE. And, you know, I think something that we are going to probably turn our attention back to, and it's worth stopping and pausing and noting that one of the existential challenges of PACE, in my judgment, is the lack of data uniformity. We truly, even at the assessment level, there is very little in the way of data uniformity and specifications and definitions. Unlike nursing homes and other models of care for similar populations, we do not enjoy that platform of commonality. So I think one of the contributions I think we can make over time is to begin to put forward ideas concerning data uniformity that can be focused on across the different, I think, data vendor environments that are used by PACE. That is maybe one of many steps, but that's certainly something I think that we are motivated to look at moving forward.
That's super interesting. Yeah, I think data uniformity is a massive issue across healthcare. I believe TEFCA should have some impact in broader healthcare, maybe not specifically in PACE to begin with. I think thinking about some of the other macro trends in healthcare and technology, the thing that is going to frequently come up is artificial intelligence. David, how are you thinking about coupling some of the initiatives on the interoperability side with AI to ultimately improve provider satisfaction, patient outcomes, and things of that nature?
Yeah, so I think the AI is like, and I don't want to get too excited, but I think it could be really game changing. And at the same time, it could really screw things up. And I'm probably going to be right? If we play it out 10 years, I could come up with examples of each one. So to Shawn's point, these complex elderly patients in a lot of ways are complex data problems. And the AI is really good at looking at those disparate sources of data, zip codes, genetic code, medical record, family dynamics, all of those food deserts, all of that information can be super, super helpful. And the AI is great with that. And I could go over examples that I think are mind-blowing where human performance gets blown away by AI, particularly computer vision and some predictive models. That being said, and it goes again back to what Shawn was talking about data and data uniformity, these models are trained on the data that we train them on. And oftentimes that data has inherent biases in them. And therefore, the resulting model will come out and act the way it was trained. And we know the inequities in care. And we have to be very, very cautious when we use models and say, this should work when we really haven't tested it in that population. The other thing I say about AI in healthcare, a lot of people go, well, we understand the risk, so we'll use it for the non-clinical pieces. And I'm like, I haven't found any example in healthcare that's non-clinical. So, well, we could help us understand surge capacity in the emergency room, or we could help us understand pre-authorizations. Those are non-clinical, right? That's different than making a diagnosis. But to me, those are clinical. Like if the ER is crowded, people die. If they don't get the meds that the person needs, there can be really bad outcomes. So we are in a clinical business. Everything that we do is to drive those clinical operations. Now, some of them are more clinical than others. But when we bring AI into healthcare, we are bringing AI into healthcare, right? It's not a chatbot that's helping me buy something on Amazon. It is a chatbot that's helping me understand my bill. And if I don't understand my bill and I don't pay it and I don't get my meds, there's clinical things. So I say AI in healthcare is AI in healthcare. And I am super excited about it. And I'm equally scared.
Yeah, David, I to completely share your both hopes and skepticism about the use of AI. And for the record, this is my personal view, not the view of NPA, because I do think that I think like many people probably on this call, we're all still getting our head around what is really realistic. We can all envision AI, right? But I think what shapes up to be the reality of the use of AI remains to be seen. But to me, I think so the guiding principles on the use of AI, it is not here to replace care. It's not here to replace decision making. It's here to enhance access to information and to inform caregiver decision making, right? And maybe even help to monitor care. But I think there's enormous potential if you can keep it in that context, at least preliminarily. But I think like anything new, I think you start with an area that has opportunity yet low peril. And I think in terms of the access to information and informing and helping to better understand the individuals we serve and the impacts of our efforts would be enormously helpful in PACE. But I think it's got a significant role in the future, but I think it has yet to be fully defined.
Yeah, I don't totally agree. I feel like the framework of it being a partner, an assistant, it will synthesize and suggest as like a partner is like a really nice framework to go into a lot of the testing, because at the end of the day, with new technology, like David said, there's going to be amazing outcomes, but we also want to know the risks and be aware of them. So I think there's a lot of ways that it can be incorporated as really a partner to team members to make their lives better and make care better, but I agree with you on it not replacing.
So
Can I give my
go ahead, David.
Robbie?
Mhm.
So when I was at Google with the NHS on top of a Cerner EHR, we tried to get the rapid response team in the hospital to respond faster to people who are going into kidney failure. And we basically started non-AI, but we gave them an app, and if creatinine went up, the rapid response team came and saw the patient, as opposed to when they didn't have the app on their phone. Literally, that was the intervention. And it normally took them 4 hours to see somebody. It went down to 14 minutes, and there were 30% less cardiac arrests and 17% reduction in cost of care. So just think of it as good UX, improved care. Then we said, okay, let's do AI. So we trained it on 70,000 patients, and it was 600,000 variables per patient. And we taught the computer to diagnose acute kidney injury. With 90% accuracy, it was able to predict who would be on dialysis 2 days before any signs or symptoms in the patient. So humans took 4 hours. If we gave them an app on their phone, they could do it in 14 minutes. The computer could do it in -2 days. So think of it as a patient shows up at the PACE program and the computer says to you, this patient looks good, their labs are good, they got no complaints, but I have a 90% certainty they're going to be in kidney failure in 2 days from now. Like mind-blowing. Anticipatory medicine blows you away. Now, that training data that we trained on was with the VA. The VA is 93% male. And then we try the app in a general population, 50% male, 50% female. And guess what? It doesn't work as well, right? So here's this thing that's amazing. And now when it gets deployed in the real world, it's got to come with a label. Use it in this population. Don't use it in this population. It wasn't trained in this population. Be careful here. Like, so that to me is the balance that's going to be really important with this incredibly powerful tool that is better than humans. And then the other thing is people go, well, how did it know? Like, open the black box. Well, one of the biggest indicators that somebody was going to go into kidney failure in that study was if a doctor ordered a certain test. It did not matter if the test got done, and it did not matter what the results of the test were. Simply ordering the test was something that was a very high indicator of this person's going to be on dialysis. And the example, we also were trying to figure out how much sodium was in hamburgers, like, and we were training the computer for, take a picture of your food. And the computer could nail the milligrams of sodium exactly. And you'd show it a new hamburger and it would tell you, 250 milligrams. So we opened the black box, and one of the biggest drivers of sodium in hamburgers was if there was paper in the picture, because the computer learned, that must have been from a fast food restaurant. So sodium goes up, if you ask a computer, if there happens to be a wrapper in the picture. So when you say these things from a clinical standpoint to clinicians, this patient's going to go on dialysis because the computer figured out the paper. The computer figured out you ordered a test. We don't even care what the result was. We don't even care if you did the test. That's also an interesting human-computer interface where we have to have discussions and how do humans feel about that and what does it mean. So a lot of things as this new powerful tool starts entering our world.
That's an exciting example. And I think taking a step back from the impact of AI and the potential future impact of AI, I want to kick it back to Shawn to hear more about data uniformity. I know, David, you touched on it again. Stephanie, you touched on it a bit. Shawn, with data uniformity in mind, what are some of the tactical things that PACE organizations can do today? And what are some of the non-clinical positive outcomes that we're looking for? Is it like easing quality reporting and compliance reporting? Are there other sorts of things that we can benefit from with better interoperability?
Yes. Short answer is yes. All the above. I think better data uniformity, certainly from the context of where we are at MPA, presents opportunities to look across the PACE community more comprehensively. The notion of gathering and possessing information that's uniform across the entire PACE community and all the participants for the sake of data analysis is really powerful. I also think that for those folks that know the PACE community, there's a lot of sharing of strategies, resources, information. It's unimaginable to me moving forward as we grow how we're going to continue to offer good advice and resources if we're really using different languages, even at the level of assessment. And then I think most importantly, and I am going to tie in a little bit to the AI issue, I've always had this vision and dream that, fast forward into the Jetson era and of the future of PACE, that we will have the ability to collect information on the people we serve, their diagnoses, the services they're provided, and what their outcomes of care are, and their service utilization patterns, and the past is prologue. So we will be able to access that information to inform the delivery of care and improve the delivery of care over time moving forward. All of that is unimaginable without some kind of data standards in PACE. And it's also kind of, I can't even get my head around how we can even think about keeping the individuals we serve and their families informed about our care and services and outcomes, unless we really have some kind of even data consistency at the program level. But I think the bigger problem is across PACE. So that would be my take.
And Stephanie, you've been to the depth of standardizing data, and you live today to tell that tale. And you built an interoperable data system, analytics system, care delivery system. What were some of those key outcomes that you saw from that? And then can you start to translate and crosswalk some of that work into the work you're doing now in PACE?
Yeah, definitely. I spent time in full risk models in Medicare Advantage and ACO REACH. And I think one of the things that those models have that is very standard is quality measures. And we did a lot of work to really embed that full risk model, including risk adjustment, quality measures that were, again, standards from CMS, and a lot of the utilization metrics and trends into the day-to-day workflows of providers. But none of that could be done without creating an extremely interoperable system. So we actually built out pretty extensive interoperability with Medicare. They offer a 3-year claims history for patients through document exchanges and health information exchanges. And again, really created a system that gave that to providers in a very easy to use and understandable format so that they could work on understanding what was a gap for patients and really working on closing those gaps. So I think it can be done, and those standards can be put in place and be followed. And while doing that, giving a really amazing product to the teams that are seeing patients and ensuring that they can really focus on patient care and focus a little bit less on entering data and all the manual things they need to do there.
Yeah, that's super helpful, Stephanie. And taking a quick look back at Shawn's overview of how data unification and uniformity can impact PACE. I'd like to get your opinion, David. Do you think there are applications of AI and some of this advanced data technology to ease things like compliance reporting or quality reporting for PACE programs?
100%. I mean, I think that's the low-hanging fruit that you could be doing now.
And
Isn't
Shawn,
that what Intus does? Are you allowed to talk, Robbie, about Intus? Like, isn't your company's, I mean, isn't when you went around with your mom, you were like, hey, I want people to spend more time helping these people instead of filling forms out? I mean, isn't that literally what we're doing at Intus?
Yeah, that is a great plug for what we're doing. And I guess, Stephanie, I can pass it to you to talk a little bit more in depth about some of the initiatives we have related to that.
Yeah, we're super excited to be building a system that is going to minimize a lot of that burden for teams. I think there's so much opportunity in what we're building with Care Hub. Again, to really create a system that is automated and easy to use and minimizes the admin burden for teams. I think we also, as part of that, want to really ensure that the technology itself is built for PACE and with PACE, and we've spent a lot of time doing that to ensure that the model seamlessly fits into workflows. And again, has interoperability at the base of it with a lot of the new technology to streamline all of the work that you all are doing and really support you in delivering good care. I think we all love this model and really believe in the PACE model and think it's like one of the best models to be giving to seniors. And if we don't equip teams with good systems and technologies to manage care, I think, that's not a place we want to be. We really want to enable teams to expand this model and give it to as many patients as we can in the country. And so that's our goal. And through doing that, make your lives a little easier. So.
Mm-hmm. And Robbie, I one part of your question I didn't address that I'd like to quickly address is the issue of compliance. And, I think as the audit protocol for PACE has evolved over time, it's kind of underscored or arguably elevated the strategic importance of the EHR as an instrument of compliance. And that is going to, I think, take greater shape moving forward. I think as we continue to see changes in the PACE audit protocol, right now it is inconceivable to me how, as a PACE program, you can really consider, put in place, and record activities that constitute compliance without good data systems, as well as the underlying data set you use within it. So, yeah, I wanted to mention that.
I totally agree with you, Shawn. That's actually such a good point. I think the systems themselves should set up the program for success with compliance. And at the end of the day, we want to make it easier for teams to stay compliant and not have the burden of having to think about that day in and day out. And so I think that was a really good point that I'm glad we hit on.
Mm-hmm.
And Shawn, how do you think about, if we drill back down into patient outcomes, data uniformity enabling better benchmarking across PACE programs? How can that better impact patient outcomes?
Well, we would have more collective information across the PACE community. As you guys in particular know, we spend at least the majority of our time in our data analysis and benchmarking services just cleaning and making uniform the data we use for analysis and benchmarking. But we consider that investment essential in order to generate accurate, reliable, and valid information over time. I think we've seen it enough up close to know that even within an existing program, there's data variation over time. So I'm enormously skeptical of PACE programs' ability to really look at themselves effectively over time without standardized data and without some assurances that that data is clean and consistent and valid. In the absence of those standards, I think it's, arguably unreliable. I do think that, moving forward, we are probably going to be moving into an era where, and I think most PACE PACE organizations would welcome this, but we have some standardized, I'll call it quality indicators, some dashboards, if you will. And I tend to like to think of them as two-sided dashboards. We should be looking and striving toward quality outcomes similar to what payers expect of us, right? I think that's the way it should work. We shouldn't be striving for quality here and trying to satisfy the payers over here. There ought to be some consistency or uniformity across those. But to do that right, you really have to risk adjust them. And to risk adjust data, you've got to have demographic and individual level data that's consistent and uniform and universally defined, right? So the notion that I'm comparing my outcomes in my program to yours, Robbie, is, it's possible today, but it's enormously challenging. And the notion of going to if the feds ever move to a set of really comprehensive quality outcome measures in PACE, I just don't see that possible unless we develop some kind of standardized assessment data that would be used to risk adjust those outcomes. So
the power to me of what Shawn is saying is not only for what he's just described, but also if you really had uniform data and shared it, a new patient shows up to the PACE program and you literally could write out their medical record for the next year. You could literally say, based on what we know, here is what's going to happen.
Yeah.
And now let's have a discussion, because if you want to get to your granddaughter's wedding, we can make this intervention, and that's going to change what's going to happen in 6 months to you. And we know with 90% certainty you're going to, have a cerebral vascular event or whatever. So the power of not only using it for driving quality and learning, the power today of that data is also becomes incredibly predictive. And that prediction to me is an amazing way to engage patients and families in behavioral change.
I actually love the point you made too, because I think what's the care plan and PACE is so central, but I think one of the really important parts of that care plan is the patient's goals, right? You said that like the goal is to get to their daughter or granddaughter's wedding. And I think when we think about a patient's goals and what they actually want to achieve, with the ability to add the predictive insights into that, it's just so central to the model. And being able to really meet patients and what they want to achieve is going to be really amazing in the future.
And Stephanie, I think you guys got pretty close to achieving that sort of technical model and vision at your previous role. What were some of the hard things you had to overcome in order to get to that vision of near interoperability?
Well, I think we're all saying, I think there's a lot of standards being put in place in healthcare, but they're not all realized today. And I think the market is rapidly changing as far as Gen AI technology and what we're going to be able to do with less standardized data. But I think there are just a lot of legacy systems in healthcare. And so I think what we found is that you're going to really have to meet people where they are and what they can do with interoperability to achieve it. And so that does not come without challenges because, again, if you have the goal in mind of getting as much data as possible and then deduplicating it and putting in that longitudinal record, you really have to work with all systems and any systems and be able to be flexible in the space where I think standards are being created but they have not been fully implemented.
Yeah, that makes so much sense. And I see we're coming up on times shortly. I'd like to pivot to some closing remarks. David, I'd like to hear from you, even more broad than the discussion on interoperability. Like, you've been able to see PACE from a few different angles today, and you have a purview across healthcare settings, the spectrum of various models of care, so on and so forth. What gets you particularly excited about PACE today and the future of where PACE can go?
Well, when I was at Geisinger, I don't think we called it PACE because there was something PACE already named in Pennsylvania, so I think it was called Life, but they were PACE programs. And I forget how many we had. I think we had 3.5. And I don't know why I said
three
that,
at
maybe.
three, and no alternative care site. Correct.
Pretty good memory, huh? 'Cause
Good
this was
memory, David.
3
very good
jobs
memory.
ago. And I love driving around rural Pennsylvania and stopping in our clinics and hospitals and stuff like that. And it was quite a change moving from Beverly Hills to rural PA. But when I would go in a PACE program, this is probably way too personal, it was incredibly gratifying to me because it was mostly women, right? I don't know what the percentage is. Is it 80% women to 20% men?
High 70%.
And they'd say I was so handsome and so young. And I was like, I'm only going. So I just kept stopping for lunch at every Geisinger Life program because for my ego, no, these are special places. Like, it's incredibly special to, I remember one time I was in one of the Life programs and it was left hand day, like, you know, for left-handers, and they had everyone hitting balloons with their left hand and stuff like that. And I'm like, this is where I want to be. I want to age in place. And there's just a bunch of caring people that are doing like amazing work, and the tech should just be in the background. So you keep hitting the balloon with your left hand. And I loved how handsome and young I felt at PACE programs. But that's it.
Well, David, you're still handsome and young, but
Thank you.
Someone needed to say that, David.
Thank you.
And Shawn, as the leader of PACE nationwide, what gets you excited? Like, what's getting you out of bed every single day to continue to be a champion for PACE?
The impact on those we serve. I grew up in a family of people that have been involved in this care for the elderly for a long time. I worked as a nurse aide in high school and always known there's a better way, and then after working in traditional long-term care associations for a long time, I kind of came to PACE, and I feel like it is the best model of care for the population we serve. So the motivation for me really rests in knowing that every day we serve more people and allow more people to age with dignity and get the best care possible, and find satisfaction in that way of life, choosing their own goals of care, and be surrounded by a group of really committed caregivers that are there not only for them but also their family. And so I think the satisfaction that I've seen, and not only data but in the words and the faces of those we serve, is enormously motivating and satisfying. So that's kind of what motivates me.
Amazing. And Stephanie, you're now a year into PACE. Why'd you make this shift, and what are you excited about?
Yeah, it's been such an amazing year. I've been lucky enough to spend a lot of time in PACE centers throughout this year and really see the model in practice. And I think by far it's the most comprehensive model, and really is the way we should be thinking about caring for seniors, I think across the board. And I think I'm super excited about, bringing new technology to really enhance the lives of the team members that are doing the work day in and day out. So very excited.
Well, thank you, Stephanie. Thank you so much, Shawn. Thank you, David. And thank you for everyone who joined us today. We appreciate your engagement and thoughtful questions. If you'd like to continue the conversation or learn more about Intus Care and how we're working to advance interoperability and PACE, please don't hesitate to reach out. I hope you all enjoy the rest of your day. That's time. This is a great panel. So thank you again to our exceptional panelists.
And Robbie, thank you for organizing it. I thought it was a really good session. So thank you very much. And David, it was a pleasure to work with you.
It's the same with Shawn, Stephanie, Robbie, so much fun. Thanks.
Thank you.
Thanks, everyone.
Take care, buddy.
Thank you.